Good morning, respected judges and friends. I'm going to present my paper on digital revolution in glaucoma screening, now offline on a smartphone. These are my financial disclosures. Sir, sir, it's not moving, sir. So Dr. Venkatesh, me and Dr. Kavita do not have any financial disclosures. Dr. Divya Rao works for Remedio. She's a medical director over there. So as we all know, previously undetected glaucoma levels, according to the prevalence studies, show that the vast majority of glaucoma in less developed nations are undetected, and about from 50% of that is advanced disease, and 20% of them are blind. So there is a need to screen there is a need to have a device which screens faster. So using this offline on the edge AI integrated on a smartphone fundus camera, it generates a referral report in 10 seconds. It can be used at any time, any place, whether it is a remote camp where there is no internet or electricity. It can be used in vision centers and also at home, and it can be used by anyone, whether it is a MLOP, optometrist, or general ophthalmologist. And this AI generates a report, and it just does not give vertical CD ratio, but it also highlights areas of concern. As you can see in the picture, it shows it highlights the RNFL defects also. So the purpose of our study was to assess the performance of this novel automated screening tool for referable glaucoma using an offline AI deployed on a smartphone based fundus camera against specialist diagnosis using gold standard slit lamp biomicroscopy. So this was a prospective cross-sectional study done between June 2022 to December 2022, with the 56% being male, and the mean average population was 53.27 years. And the major first outcome was diagnostic accuracy of this AI against the glaucoma specialist. And we refer by referable glaucoma, we mean both definite glaucoma and dyssuspects. So a sample size of 200 patients was calculated such that the measured rate of discordance in referable glaucoma between the AI and the glaucoma specialist would differ from the true rate of discordance by less than 8%, which is normally 10 to 50%, and the sensitivity should be of at least 80%. An equal distribution of glaucoma, dyssuspects, and no glaucoma was aimed at between these 200 patients. We included all patients above 18 years who were willing to give consent, and we had a glaucoma group, a normal control group, dyssuspect group, and we took fields which were reliable with the false positive and false negative of less than 20%. We excluded all patients who had acute conditions where narrow angles where dilatation was contraindicated, retinal pathologies precluding the view of the disc, or any media opacity cataract grade more than nuclear sclerosis grade 3 was excluded. And also participants who were, in the opinion of the investigator, who would prelude the participation in the study, like uncontrolled intraocular pressure, active infection less than 3 months post glaucoma filtering surgery, and also those in whom the imaging was contraindicated, whether the patient was hypersensitive to light or recently underwent photodynamic therapy. So this is a flow chart. We had 3 groups: normal, dyssuspects, and known case of glaucoma. They all underwent vision testing at non-Snellen's chart, and then an undilated fundus photo was taken by the Remedio fundus on phone camera. If the image sufficient, if the quality of the image was sufficient, the AI was run on the image, and the AI interpretation and the VCDR was noted. And if the image quality was not sufficient, 2 attempts were needed, were again given to the optometrist or the MLOP to take a sufficient quality. Again, if it is not coming of sufficient quality, then the patient was dilated after all these preliminary testing like IOP, gonioscopy, visual field testing, and then pupillary dilatation, and then after dilatation, grading of the cataract and dilated fundus photo was taken, followed by OCT. Again, the AI was run for interpretation only on those cases where the undilated image was not good enough. So, and then all the findings were noted, and then finally these patients were given to a glaucoma specialist who was masked to whether this patient is a part of the study or not. So as we were doing normally, how we see a glaucoma patient or a dyssuspect or a normal, we did that. Wherever required, we did HFA and OCT. So these are the results. According to glaucoma specialists, there were 94 plus 55 referable glaucoma, which includes glaucoma and dyssuspects. And according to AI, it was only true positives were 128. Glaucoma specialists gave 149 as referable glaucoma, and according to AI it was 128. So the sensitivity or the true positivity was 85.9%. For no referable glaucoma, according to the specialist, there were 66, and according to AI, the true negatives were 64. The specificity was 97%. So the sensitivity was 85.9, specificity was 97%, positive predictive value was 98.5, and negative predictive value was 75.3. So sensitivity and specificity was high, and it was like It was comparable to the specialist diagnosis, and AI showed robust performance in detecting referable glaucoma with minimal overcall of normal cases. So, to conclude, novel AI integrated on a portable fundus camera can have a significant impact in screening for referable glaucoma. It can be implemented in population-based or vision center-based model by minimally trained personnel. It can be a support tool for ophthalmologists through timely referral, especially in resource-constrained environments, and it has the potential to make glaucoma screening accessible, affordable, and effective. The limitations of our study was AI was evaluated only in Indian population, so generalizability across the populations is to be determined, and performance evaluation based on severity of glaucoma has not been done, so it has to be done in the future. Practical implications: Remedio fundus on phone with offline AI for glaucoma can be used for mass screening at remote places, schools, community halls, and workplaces, and AI can help in reducing unnecessary referrals. Thank you.